Hey guys, so today we'll be discussing colorectal cancer. This chronic illness can have a huge impact on those that it affects and is a huge pain in the butt. Are you ready to get to the bottom of this? So, I'll be explaining what the disease is, the risk factors which increase its prevalence, and the symptoms associated with it. Meg is going to discuss the statistics of the disease and the role of the multidisciplinary team, and Bree will talk about the policies and strategies employed to reduce the number of people it affects and the management of the disease. Cancerous cells are created during cell replication process of mitosis, in which a mistake or mutation occurs as the DNA replicates itself, creating a cell with altered functioning. Usually these mutated cells are picked up via cell markers and the immune system employs killer T cells to eliminate them. But malignant cancerous cells are much harder for the body to notice and kill. On top of this, they multiply uncontrollably fast into masses called tumours. Cancerous tumours are malignant, while benign tumours aren't cancerous as they don't spread and grow as fast. Cancers may fall under various subcategories dependent on what type of cells they arise in. Colorectal cancers are usually carcinomas, in that they form from epithelial cells, usually being those in tissue linings on the inside or outer body surfaces. Cancerous tumours, as they progress, will break through tissues into cavities, blood vessels, or the lymphatic system and metastasize and spread to a different area of the body. Part of the reason cancers are so dangerous is that the longer they are left untreated, the lower the chances of full recovery are. On top of this, many cancers are asymptomatic or without symptoms until the later stages. Some symptoms for bowel cancer include any changes to the bowel movements like the frequency, shape or appearance, any pain or distension of the gut, and any kind of blood in the stools. Unexplained anemia or a low red blood cell count, rectal or anal lumps, frequent gas or cramping, and a feeling that the bowel hasn't fully emptied after a movement are also symptoms. A number of risk factors for colorectal cancer exist. Many involve what gets put into the body, as a higher risk exists for those with a larger intake of red or processed meats, alcohol, fatty foods, or those who smoke. Physical exercise decreases a person's risk, as does consuming dairy or calcium products and whole grain foods with a dietary fibre. Non-modifiable factors include age and genetics, with screening programs and information sent out to those who are over 50.
Hi, I'm Meg and we're going to talk about the prevalence of colorectal cancer now. In 2015, colorectal cancer was the second leading cause of cancer deaths in Australia. It is estimated that it will remain the second most common cause of death from cancer in 2018. As you can see in this graph, there is a significant gap between the incidence of colorectal cancer and the mortality rate. This shows that if diagnosed early enough, colorectal cancer is very much treatable. There's also a higher incidence in males than in females, and in 2018 it is estimated that the risk of an individual dying from colorectal cancer by their 85th birthday will be 1 in 49 males and 1 in 63 females. Cancers detected by the National Bowel Cancer Screening Program, which we'll talk about later, were diagnosed at an earlier stage than symptomatic cancers. With the continuation of the bowel cancer screening program, the statistics show that the early detection of bowel cancer will eventually lower the mortality rate and see the survival rate climb. We'll talk about early detection and the role of the MDT. The stage at diagnosis is the most prevalent prognostic factor, as was demonstrated by the previous charts. GPs and nurses are predominantly responsible for the early detection of colorectal cancer, as they have the initial contact with the patients. High-risk patients, such as those with an inflammatory bowel disease, familial history, obesity, diabetes, or a history of alcohol abuse, need to be informed and monitored with more often. They are responsible for ensuring that patients are referred to the right people and the right services, and that the correct tests are done as soon as possible so that the cancer is caught at the earliest stage. Bowel screening and pathology tests are reviewed, and GPs are again responsible for referring the patients on for treatment, and the nurses will assist with developing care plans to maintain the patient's quality of life. The treatment that a patient will receive depends upon the stage of the cancer. The later the stage, the more advanced the cancer, and hence the harsher the treatment required. Surgical removal of the cancer and the bowel surrounding is usually the first step. If the cancer is more advanced or if it is an aggressive type, such as rectal cancer, then chemotherapy will also be required after surgery. During this treatment, nutritionists will often be involved, as changes to diet may be required, and chemotherapy can cause vomiting and an intolerance to food. If a stoma is required to rest the bowel, or if the bowel is permanently removed, then a stoma care nurse will make sure the patient is educated so they can look after their own stoma. They will also educate the family on the stoma and inform them of support networks available to them. Radiation therapy can also be used for later stage colorectal cancer, especially rectal cancer, and interventional radiotherapy team may also use image-guided technology to target the cancer without surgery. If the cancer does advance to stage 4, it is likely that a palliative care team will need to be involved to treat the symptoms of the colorectal cancer.
Before discussing management, it's important to note 2 facts. Firstly, 90% of colorectal cancers can be successfully treated if detected early. And secondly, recurrence post-curative resections for colorectal cancer is extremely common, up to a rate of 40% in some patients with stage 3 cancers. These facts highlight the importance of screening in the management of pre-diagnosed patients, but also the importance of ongoing management in the diagnosed patient. Currently, there are 2 major strategies in Australia that influence the management of colorectal cancer. These 2 strategies are the National Bowel Cancer Screening Program and a set of clinical practice guidelines for the screening, treatment and management of colorectal cancer. As nurses, we play a crucial role in the promotion and implementation of these 2 strategies. As nurses, it is important that we understand the screening program, educate patients on it, and promote the use of the free screening where possible. It is also important to abide by the practice guidelines to help achieve the best outcomes for individuals. But this too means we must strive to advocate for the patient when guidelines and recommendations are not being met in a timely and appropriate manner. The National Bowel Cancer Screening Program is a population-based screening. It utilises a biannual immunochemical fecal occult blood test to detect the presence of blood in faeces as an indicator of colorectal cancer. Screening programs target Australians aged 50 to 74 years of age who have no signs and symptoms associated with bowel cancer. This is the screening age bracket, as it is renowned for the significant increase in the likelihood of colorectal cancer development. The screening test is quick, easy and simple. It requires the individual to obtain a stool sample that is then sent for pathological testing. Early detection is vital, and screening is often the first stage in early detection and treatment. As nurses, it is important to promote the program and educate patients as it is common for patients with early stage colorectal cancer to present with no signs and symptoms. It's worthy of mentioning that individuals with a family history of colorectal cancer may be required to commence screening as early as 40 years of age. The clinical practice guidelines explore a number of recommendations in regard to the best practice for prevention, early detection and management of colorectal cancer. This document is tailored towards numerous health professionals, notably GPs, however remains particularly relevant to us as student nurses. Some of the notable recommendations are as follows. The time from presentation to diagnostic colonoscopy should be no more than 120 days. As nurses, it's important we advocate for the patient where appropriate to ensure that this time frame is abided by. Follow-up after curative resection is important for the detection of recurrence. Recurrence is common, so it's important that we assist in educating the patients on the importance of complying with follow-up appointments and testing. There are specific recommendations regarding specific alterations in the screening program for individuals with a family history of bowel cancer. Depending on the degree of relation, severity of the cancer, and the number of relatives with bowel cancer will determine what the alteration is. Further information can be found in the Clinical Practice Guideline policy obtained from the Cancer Council or Department of Health. Should you have any questions, please feel free to contact any of us. Alternatively, there are a number of great resources available for yourself, but also as a resource for patient education. So, Let's help ensure bowel cancer gets nipped in the bud.